I actually have the great honor to present our speaker for this evening, Neha Shah. During my fellowship, the name Neha has really been synonymous to nutrition due to her really vast expertise in specializing all things nutrition related in GI and hepatology for the past 16 years. She received her nutrition degree along with specialized training her MPH in nutrition at Loma Linda. She's currently at UCSF with us specializing in GI, IBD, intestinal rehabilitation, and currently owns a GI and liver nutritional private practice, Neha Shah Nutrition, with the intent really to really specialize in GI, liver nutrition, and care for our patient and communities. Previously she made really significant contribution to the implementation of nutrition at Stanford through building, establishing a nutritional service for both GI and liver programs, developing outpatient nutritional support, intestinal rehabilitation in patients who are on enteral parenteral nutrition, especially those in short bowel syndrome. And she also served as the intestinal transplant dietitian for the care of pre and post-transplant patients. Scientifically, she has authored numerous articles, editorials, book chapters related to nutrition in our field. And lastly, she's really involved in several professional organizations. She's a co-founder, director of operations in the International South Asian IBD Alliances, which they also have a lot of great webinars themselves. She's an active member of the Crohn's and Colitis Medical Advisory Committee of Northern California. And really her goal is to continue to improve GI and liver initiatives to advance really nutritional care and ultimately improve outcome. So without further ado, Neha, I really appreciate you being here.
Thank you for that kind introduction. Next year will be my 20 years as a GI and liver dietitian for the most part, and I've been in this field for 18 years. So let's just say I've seen a lot over the years in this specialty, and it is an honor to bring forward nutrition management in NAFLD because it's definitely a big, important piece in the treatment of NAFLD. Okay, so I'm going to go ahead and get started. I have listed my disclosures here. Okay, so our agenda for today, one is to help meet our learning objectives for today. We will start with the basics. A mini primer on normal liver anatomy and physiology. I'm not clear of everyone's background here on this webinar today, so I do want to make sure I cover some basics. The role of the liver in our nutrition health and the role of liver tests used to assess the status of the liver. We will review definitions and types, and from a nutritional perspective, pathophysiology of NAFLD development. We will also discuss how to identify patients at risk. And finally, we will explore nutrition evidence-based interventions to help you in treatment and management of NAFLD. We hope after today, you'll be able to roll up your sleeves and be ready to put its concept into practice with your patients. So we're going to start with the basics. So with that said, the liver is, truly a complex anatomy. And if many of you are hepatologists on this call, all of you are familiar with this, or for those who are not, it'll just be a quick overview. We are going to start on the left with the visual of the digestive system. And the liver is an accessory organ to the gastrointestinal tract. It's located in the right upper abdomen, right under the diaphragm, and over the stomach. The hepatocyte is the cell unit in the liver and makes up 80% of the liver. Moving over to the right with the up and close and personal visual of the liver is divided into the right and left lobes, with the right lobe being the larger section of the two. We're going to go in order, starting from the top. The right and left hepatic ducts drain bile from the right and the left lobes of the liver, respectively. The hepatic portal vein carries blood from the gastrointestinal tract to the liver, containing nutrients from digestion from our diet. Note that the hepatic portal vein is not the same as a hepatic vein, which carries blood from the liver to the heart. Nutrients delivered via the portal vein are used for synthesis of other substances before reaching systematic circulation. The common hepatic duct is formed with the right and left hepatic ducts coming together. The common bile duct is formed when the common hepatic duct joins with the cystic duct from the gallbladder. The cystic duct involves bile flow between the gallbladder and the common hepatic bile ducts. And certainly, finally, the common bile duct delivers bile to the duodenum upon stimulation from the enteric hormone CCK when nutrients, especially of fat, enter the duodenum. And moving forward, the role of the liver, it plays a huge role with nutritional metabolism. In its physiology, the liver plays a role in synthesis, storage, and excretion of nutrients. To highlight a few, the liver is involved in metabolism of all macronutrients. And macronutrients, that word refers to carbohydrates, proteins, and fats. Carbohydrates through glycogenesis, glycogenelysis, and gluconeogenesis, all activated at different parts of the day, even during the night, depending on the availability of substrates coming in from the diet or within our body. And certainly lipids through lipogenesis, synthesis of fats, lipolysis, a breakdown of fats, and beta oxidation as well. And then certainly protein through transamination and deamination. The liver also gives a home and provides storage of many nutrients, such as the glycogen as stored carbohydrates and vitamins such as vitamin A and B12. Excretion involves the elimination of bilirubin into bile and the conversion of ammonia to urea for its excretion into the urine. Detoxification involves modification of medications and other potential toxic substances for less toxicity, or its catalyst for eventual excretion. And why this is important is because with NAFLD, a lot of these nutritional roles that the liver plays, it does not necessarily get significantly impacted, but we need to be able to treat NAFLD at its early stages. As with NAFLD is with risk for progression to cirrhosis and fibrosis, in which over time, the functions of the liver can be all impacted here, impacting nutritional status significantly. So we want to treat NAFLD early on to protect all of the functions that I just outlined right here. Liver function tests, and we're going to also discuss liver chemistry tests. There are differences. As with any interpretation of laboratory tests, it may provide clues of underlying medical concern, but it's not diagnostic alone. The liver test, albumin, conjugated bilirubin, and prothrombin time, INR, are known as liver function tests, as the markers here reflect function of the liver. I often see in the notes LFTs just for any and all labs related to the liver, and certainly these are what we consider to be liver function tests. A reduction in albumin levels may either indicate liver disease or due to an inflammatory process in setting with a significant illness. So albumin levels, when the levels drop, it's not always reflective of a nutritional change. Bilirubin exists in unconjugated and conjugated forms. The majority of bilirubin circulates as unconjugated bilirubin, and then certainly when unconjugated bilirubin reaches the liver will conjugate for its excretion into bile. An elevation in total bilirubin and conjugated bilirubin levels can occur in significant liver disease, and then certainly the INR measures coagulation. Prolongation of the INR may occur in setting of liver disease when concentrations of the clotting factors fall below 10% of normal levels. Cholestasis may prolong the INR due to possible vitamin K deficiency. So again, we need to be able to apply multifactorial causes of why these labs may rise or fall, and that certainly. And going back to the vitamin K deficiency may arise in a setting of impaired bile flow that may not allow adequate absorption of vitamin K. As a general rule, in the absence of liver disease, an INR that's prolonged may indicate steria as well. And with liver chemistry tests, these tests reflect liver injury, and certainly, from my understanding, are not considered to be liver function tests. So the liver tests, AST, ALT, and alkaline phosphatase, certainly, again, its elevation may suggest injury. AST is present in the liver and other organs, including cardiac muscle and skeletal muscle and kidney and brain. ALT is present primarily in the liver, and thus is more of a specific marker for liver injury than AST. And then certainly AST, any increase there without an elevation in ALT could be possibly suggestive of cardiac or muscle disease. Alkaline phosphatase is found in the liver as well, and other areas of the body, also in bone. And a significant elevation in AST and ALT levels may reflect liver injury. And in contrast, a significant elevation in alkaline phosphatase level may indicate cholestatic injury as well. And then because alkaline phosphatase is also found in bone, alkaline phosphatase may also be fractionated as isoenzymes to help learn the origins of the elevation, whether it's the liver or the bone. I often will order these labs. I do manage a lot of patients on parental nutrition, and a lot of these patients are also, they do develop metabolic bone disease along with liver disease associated with their parental nutrition. So it just helps me understand a little bit more where we're at with liver versus bone as an example as well. Okay, types of NAFLD. Many patients with NAFLD just rarely show symptoms. There's no laboratory test available to diagnose NAFLD. However, liver chemistry tests could be elevated as the first clue, but not always. For defining NAFLD, there must be one, evidence of hepatic steatosis. I'm going to call it HS, a formal term used to indicate accumulation of fat within the liver, either by imaging or by histology. And then two, lack of other causes, such as significant alcohol consumption. Several imaging techniques are available. Certainly is beyond my scope of practice to interpret imaging. I leave that to the medical team, but certainly I will highlight the FibroScan, which is often utilized for imaging, is a specialized ultrasound that evaluates for HS and for fibrosis as well. And that term, which is scarring within the liver. And certainly histology may involve a biopsy when needed. Significant alcohol consumption is defined as greater than 30 grams per day in men and greater than 20 grams per day for women for the past 2 years. And then with NAFLD, it has several phenotypes based on histology. Today, we're just going to focus on the primary two. NAFLD in green is defined as the presence of 5% HS without signs of any ballooning, which involves swelling and damage to the cell. And NASH in yellow, on the other hand, is defined as the presence of, again, a 5% HS, but in contrast to NAFLD, there is inflammation along with hepatocyte injury and may or may not even include fibrosis. NASH increases the risk of fibrosis as well as cirrhosis. So we want, again, to treat NAFLD in its early stages to slow down this progression. The gold standard for diagnosing NASH is a liver biopsy. And again, this is all deferred to the medical team to determine what would be appropriate or not. Okay, so now we're going to move forward into discussing risk factors to NAFLD. So metabolic risk factors, there's several, there's many actually. I listed the top three here: type 2 diabetes, dyslipidemia, and metabolic syndrome. All diagnoses can all coexist together. Patients with type 2 diabetes have a higher prevalence of NAFLD, about 30 to 75%, and with a higher risk of developing NASH with fibrosis. NAFLD also increases the risk of type 2 diabetes, which is why all patients with NAFLD should be also screened for type 2 diabetes as well. In insulin resistance, this is when the body cells are just not responding as well to the insulin that is aiming to bring in glucose into the cells. And as a result, there's an elevation in glucose levels. Insulin resistance also increases the risk for type 2 diabetes. They're just all interconnected. As you can see, patients with NAFLD are twice as likely to exhibit dyslipidemia as those without NAFLD as well. With dyslipidemia, high triglyceride, low HDL levels are commonly seen in patients with NAFLD. Metabolic syndrome involves a constellation of risk factors, including abdominal obesity, elevated triglyceride levels, low HDL levels, elevated blood pressure, and high fasting blood glucose level, in which all, again, can increase the risk for NAFLD. Insulin resistance may also exist with metabolic syndrome as well. And then certainly metabolic syndrome is a strong predictor for the presence of NASH and could be likely used as a reason per discretion of the medical team to obtain a liver biopsy. Okay, weight gain or not, and I will explain why in NAFLD. So the presence of weight gain over time or achieving overweight and obesity per body mass index, BMI, are associated with an increased risk of NAFLD and its progression. With body fat composition of an increase in visceral fat accumulation, there's a higher risk of insulin resistance, cardiovascular disease, and fibrosis, regardless of body mass index. Visceral fat is more metabolically active and inflammatory than subcutaneous fat, and certainly contributes most to the risk of NAFLD. Although NAFLD is commonly associated with obesity, it can also occur in patients with a BMI of less than 25. I definitely have seen this in my practice where, which is why NAFLD should not be viewed only as primarily a disorder related to obesity. Often my patients that come to me were told they need to follow a diet to lose weight, and which is a valid reason to send the patient to the dietitian, but it is also important to look at all the risk factors that are present to help treat NAFLD, regardless of BMI. The prevalence of NAFLD in lean patients varies from 4.1% in the United States, and lean patients with NAFLD have been shown to have higher insulin resistance, visceral fat accumulation, and less muscle mass. So overall, like I mentioned earlier, it is just important to evaluate the prevalence and the characteristics of the person sitting in front of you, regardless of any type of weight gain or BMI. Okay, lifestyle risk factors. Certainly a diet high in saturated fat and cholesterol, a diet high in fructose, a diet low in dietary fiber are all diet-related risk factors. Sources of saturated fat and cholesterol come from animal protein and animal fat. Sources of fructose, they can occur naturally. It can also occur synthetically. So natural sources of fruit, fructose is found in fruit. So that's a natural source as well as honey, but high fructose corn syrup, agave nectar, even table sugar, because sucrose is a combination of fructose and glucose. Dietary fiber, this is found in fruits and vegetables and whole grains and legumes. A lot of you may know where all the sources are, but I find a lot of patients don't. And we have to go over the terms and the sources of how we can reduce these risk factors if we're seeing this in a patient's diet. Certainly, in turn, the opposite of a diet higher in fiber and lower in added sugars and lower in saturated fat and cholesterol has been associated with a reduction in risk to NAFLD. Okay, this is one of my favorite slides, and I actually show this slide to every single patient that has come my way for NAFLD, because I find the more that they understand the background of and how NAFLD may develop from a diet perspective, it really hits home from that angle and what we need to focus on. So the metabolic pathways of focus here is metabolism of excess fat and metabolism of excess sugars, primarily of fructose and glucose coming from the diet. The excess fat and excess sugars are both used to promote lipogenesis within the liver. And then we're going to start on the left, looking at the metabolic pathway for dietary fat. Dietary fat is incorporated into chylomicrons in the small bowel, which then are released to transport fat to the adipose tissue for uptake. If there is insulin resistant present, remember that insulin not just uptakes glucose, it needs to uptake fat as well. Then fatty acids are released from the adipose tissue and then travel to the liver. Now, looking at the right of the metabolic pathway for dietary sugars, excess fructose and glucose are converted to acetyl coenzyme QA, and which is used as a substrate for lipogenesis in the liver. Excess fatty acids that are not utilized for oxidation or for triglyceride synthesis within the liver to be incorporated into VLDL may lead to the production of lipotoxic fats, which are pro-inflammatory and may potentially contribute to liver injury and inflammation. So the target for diet therapy is really looking at excess fat and excess sugar and the type of carbohydrates and the type of fat that we need to encourage our patients to eat more of and as well as less of. Okay, and then finally, lifestyle risk factors, again, is related to physical activity. Sitting time, certainly prolonged sitting time, 8 hours a day, has been associated with an increased risk of NAFLD. This could be sitting at the computer or laptop or playing video games or driving for long hours or reclining in a chair or lying down often on the couch or bed. And certainly less than 150 minutes a week of aerobic activity. For some of the literature out there, this is defined as physically inactive. And again, that can potentially also contribute to NAFLD as well. Okay, so now moving into treatment of NAFLD. So interventions for NAFLD, it's definitely multiple interventions that can be involved here, and it really requires a multidisciplinary team to implement all of this. As a dietitian, I am going to focus on diet and physical activity as well, and a little bit on weight management as well, and certainly other realms of interventions. You know, eating at the end of the day, it goes beyond the food. We have a mental relationship with food as well as a physical relationship. So addressing psychosocial elements and treating the underlying diagnosis and adding medications to treat the underlying diagnosis are all going to be helpful for NAFLD management. So it is known that weight loss on purpose can reduce NAFLD. And certainly with that said, this diagram on the left certainly kind of shows the degree of weight loss and to what percentage it can reduce the presentation of NAFLD. Certainly, weight loss on purpose can be impactful to reduce NAFLD, as I mentioned earlier. Weight loss of 3 to 5%. Improves HS, and then certainly a greater weight loss of 10% has been shown to reduce NASH and fibrosis. And certainly weight loss over time has been shown to reduce adipose tissue and improve insulin sensitivity, in which all can contribute to a reduction in NAFLD. Although weight loss on purpose is, definitely it's valid, and we know why it's recommended for those patients with NAFLD, but achieving and sustaining weight loss it's really difficult for many patients. A common recommendation at times, the only recommendation as patients have reported to me, is that they were told to lose weight. And although, again, very valid, weight loss on purpose, it may not be the sole focus for treatment, as it may not be always appropriate for patients with NAFLD, especially if in a setting of disordered eating, significant psychosocial barriers, significant access to food. I mean, there's a lot of different reasons why. But we also know that modifications in diet and increasing physical activity has been shown to reduce NAFLD independent of weight loss and its associated metabolic risk factors. And this is a primary focus when I work with my patients. And over time, if I'm able to help them implement a sustainable diet that can help protect their liver long term, then I've seen also weight loss to follow. For those with impaired relationship with foods, body image, along with presence of disordered eating, again, weight loss on purpose may not be the ideal focus. I also specialize in gastrointestinal disorders. So for my patients, I've seen patients diagnosed with NAFLD and SIBO, NAFLD and irritable bowel syndrome, NAFLD and IBD. I think the last patient I worked with had celiac disease, gastroparesis, kidney stones, and NAFLD. So again, when you're dealing with multiple diagnoses, promoting weight loss, especially if they develop malnutrition, again, it may not be always appropriate, but we can still work with modification of diet, especially to include plant-based foods that could be tolerated, and an increasing physical activity as tolerated to achieve what we need to achieve. Okay, the Mediterranean diet. So, couple of things here. It is a diet, it's plant-based. It does not mean it's a vegan diet or a vegetarian diet. It's a diet high in dietary fiber, again, high in fruits, vegetables, whole grains, and legumes. It's a diet high in phytonutrients. And for those who do not know what phytonutrients are, these are natural substances found in our plant-based foods that function as antioxidants. And certainly it can be potentially anti-inflammatory. Unsaturated fats, these are your mono unsaturated fats and your polyunsaturated fats through avocado, nuts, seeds like chia seeds, or even like extra virgin olive oil or olive oil that we want to bring in more often. And then it's also a diet low in saturated fat and low in cholesterol because its emphasis is on plant-based foods and treating the animal protein and fat like a little bit more like a side of the meal or not all the time with the meal. So this is the diet that has been really have high interest to bring forward to treat NAFLD. Okay, so with the Mediterranean diet patterns, one aspect is I've seen patients Google Mediterranean diet and they're pulling up a list of foods that are commonly eaten in Europe. And or if they have GI issues, they're like, I can't eat any of this. And one thing to stress with patients is also a diet pattern. And the way I explain it to my patient, it's a framework. So guidelines of how often most food groups should be consumed for daily or weekly consumption. And then each meal daily, olive oil, whole grains, vegetables, fruits, legumes, and nuts. I always tell my patients to the best of your ability, you're not a robot at the end of the day. So to the best of your ability, what are foods that you normally would enjoy or foods that you normally would tolerate within these food groups that you can bring in more often? The focus is always going to be additions versus elimination. These food groups are the core of the diet. And then certainly sources of animal protein between dairy, poultry, and eggs are definitely allowed on the diet. May not need to be always part of the diet daily, but it can be done, sprinkled in small amounts, as long as there's plant-based foods included with those foods. Certainly, fish is allowed for consumption, a great source of omega-3s twice a week, 3 times a week. And consumption of meats or sweets is really done on occasion, maybe for special occasions, shared with others, not every day. And that's how I would encourage those to keep those foods in the diet, especially if they have some favorites or whatnot. So overall, I can't stress enough, it's also a diet pattern that can be followed. And then those with even specific cultural food preferences, how do we fill in the blanks that would, the cultural fruits, the cultural vegetables, the cultural way of consuming a little bit of dairy, like how does that all fit in with the Mediterranean diet? Okay, so a couple of studies here with the Mediterranean diet. This study came out maybe a few years ago, 5 years ago, and certainly in a 12-week prospective parallel group, a randomized controlled trial of 56 adult patients with NAFLD. They were randomized to either follow the Mediterranean diet or the low-fat diet. Both were isocaloric, meaning they both had equal amount of calories and equal distribution between all the macronutrients. And with the Mediterranean diet, the patients were given 750 grams of nuts, almonds or walnuts, and 750 ml of olive oil to be consumed along with the Mediterranean diet. It was given every 4 weeks at a visit. And the low-fat diet, they were given 1 kilogram of natural muesli, consists of oats and whatnot, and then 200 grams of low-fat snack bars. I do not know the whole composition of the snack bars. And the parameters that were measured was total cholesterol, serum triglycerides, and certainly hemoglobin A1C, and then certainly HS as well. And they were asked, again, to follow these diets for 12 weeks. And then after 12 weeks on both diets achieved a significant reduction in HS as well as a reduction in ALT levels. But only with the Mediterranean diet, they have seen another reduction in total cholesterol, triglyceride levels as well, indicating there could be like a cardio benefit here. And there was minimal weight loss with both diets. And the reason I wanted to highlight this study is that this reduction was achieved without weight loss. So again, weight loss can be definitely a valid goal to reduce NAFLD, but in order to really help our patients move forward and learning how to develop new habits, it's going to involve, starting with building a foundation with the diet that we would want them to be on and go from there. Physical activity. Okay, so there are distinctions in the terms of physical activity and exercise. Physical activity is referred to as any movement associated with the skeletal muscles that assists with increasing energy expenditure above the baseline of the resting energy expenditure. Exercise is referred to physical activity that is structured. It's kind of done on a repetitive motion and carried out over a duration of time, like 30 minutes on the treadmill at a certain pace. That's an example of exercise, where physical activity could be walking to the grocery store and back, or doing household chores. The United States Department of Health and Human Services issued the physical activity guidelines for Americans 2018, that's the newest version, and really outlines recommendations for the type and frequency and duration of physical activity. And this is important because this is something that can be taught to patients. And how do we even, if they already are not physically active, how do we start working with them and moving them towards meeting the minimum required? As I already mentioned earlier, that physical activity independent of weight loss can also reduce NAFLD. And certainly physical activity here, aerobic activity and muscle strengthening through resistance training. The level of intensity for aerobic activity is characterized as moderate or vigorous intensity. And certainly the recommendations for aerobic activity here is that should be at least 75 minutes a week of vigorous intensity, such as running, or a minimum of 150 minutes a week of moderate intensity, such as walking. How that ties in with NAFLD, again, both are associated with a reduction in reducing NAFLD. So in this one particular study, it's an early study for many, many years ago, but the reason why I like to highlight it is that at least a lot of the patients I spoke to, they'll tell me, I don't have time to take a fancy aerobic class. I don't have time to sign up for a HIIT training. And walking, it's pretty, I'm hoping it's simple for most, but we need to learn what the challenges are. So in 45 adult patients with NAFLD, these patients walk on the treadmill for 40 minutes a week, 3 times a week for 8 weeks. And the parameters that were monitored is weight, waist and hip ratio, BMI, AST, and ALT, and there was no control group. And then certainly after 8 weeks from baseline, there was a reduction in weight, as well as the waist hip ratio, which makes sense because there's a weight loss, and it was quite significant. And then certainly there was also a reduction in both AST and ALT with that achievement. So again, I want to stress that, walking is a simple form of exercise, and if that's something that patients can explore and feel safe with it, it's accessible, it's doable, that can be easily brought in. And then certainly with muscle strengthening exercises, certainly another study here in 53 adult patients with NAFLD, all these patients were not physically active prior to the study. Certainly they were randomized. The muscle strengthening group did just push-ups and squats 3 times a week for 24 weeks. It's about 3 sets of 10 for each of them. And then the control group, it was 150 minutes of physical activity with a restricted diet. The study did not disclose what type of physical activity or what type of diet, so I think that's a big limitation there. And then certainly several parameters were collected: weight, BMI, ALT, lipid profile, triglycerides, fasting plasma glucose, plasma insulin, insulin resistant index, and of course measurements of HS. And what the results showed is that according to the study investigators, that they're, the resistance training that's been done for 24 weeks has contributed to a reduction in HS, ALT, and insulin resistant index, far more than the control group. But again, I'm not clear what the physical activity was of the control group. So I interpret with a bit of caution, but at the same time, both muscle strengthening can certainly improve insulin sensitivity with that uptake of fat and glucose, and I can see how that could be a benefit. Okay. And then certainly with that said, I think I already mentioned this. Okay, sorry, oh, here we go. Okay, so practical application. So what I want to do right now is share some of my strategies of what I go over with patients. We're all looking for a starting place, and know that when patients are learning how to eat a new way, it's a skill development. It goes beyond the foods alone. They're trying to figure out how to fit this in with their family. They're trying to figure out grocery shopping. They're trying to figure out how to dine out. They're trying to figure out, okay, do I need to learn how to do something differently in the kitchen? There's a lot of different elements here. So how I work with my patients, I would say most of my patients have come my way, and it's really a step-by-step process. So I really start with a food group or two. You cannot move into meals or recipes or meal plans until a foundation is built within the diet. And that starts with having the food groups in place, as much variety as we can, so we can go there. So I usually start, like I said, I start with a food group or two at a time, and I build along the way. And it's also patient engagement. Where do we want to start? What would be helpful? I know with my GI patients, like, oh no, I can't do vegetables. That's just going to make me sick. I'm like, okay, we won't go there just yet, because we need to be able to have the patient's buy-in in order to start somewhere. And then kind of go through all the different food groups here. So as I mentioned earlier, treat the animal protein as a side. It's sprinkled into a food full of plant-based foods. So perhaps if one wanted to eat chicken, can they throw that into soup or into a salad? If one wanted scrambled eggs, can we add some minced spinach and bell peppers to that? Can we, if you're going to do like a casserole, again, a side of vegetables with that. If we're going to do like a lentil soup, if one wanted to have some animal protein in there, that's fine. Again, it's paired up with the plant-based foods and treated like a side, but it's not the main entree. I think that's one thing I focused with my patients. Plant protein, definitely important. So with that said, plant protein, that's the category of legumes, nuts, quinoa, edamame, tofu. It's interesting because when I ask patients, so tell me a little bit more about what type of protein you eat, they automatically go straight to the animal protein. And when I talk about plant protein, it's a blank expression on their face. Like, what do you mean by plant protein? So this tells me that this is an area of enhancement with the diet. And most of them really don't have legumes or tofu or edamame often in the diet, or a handful of nuts. It just really depends on where their diet is at. So again, a lot of these recommendations, where do we start and how do we build from there? So add a legume. Would that be maybe a lentil soup, half a cup once a day? Maybe I give the patient several options for a plant protein, and they can choose when they want to add that into once a day. So they need to be able to practice this skill in order to feel like it's going to become a habit. Nuts or nut butters, all that is perfectly fine as a part of a diet for NAFLD. On toast, in salads, part of a smoothie, all that can be perfectly okay to have. For my patients with GI diagnosis, this is where they're a little fearful of fiber at times. So again, blended versions, cooked versions, taking off the skin, whatever tolerable fiber forms they can handle, that could be also of consideration. Adding fruits and vegetables, a lot of them don't have them in the diet, or it's not every day, it's here and there. So a common recommendation I'll make to patients is that, can you add a fruit and a vegetable once daily, or I'll let them decide what's their comfort level at, like maybe it's 3 times a week, like what can they do? And like I said, the food choices at the end of the day, we need to have a system in place. So many of them actually do enjoy eating fruit, but they don't feel like cutting it up. They don't feel like dealing with the spoilage. They don't feel like, there's a lot of different reasons that they're given to me. So again, that system before fruits and vegetables are eaten, can we buy them pre-cut? Can we buy them frozen? What is the easiest way to bring them in to help you do this? If they don't feel like cutting up a pineapple, but they love pineapple, fine, they can get frozen pineapple or eat pineapple when it's easy for them. Like, you don't have to have every single fruit or veggie in your diet, but I do encourage fruits and veggies 5 servings a day. Whole grains, oatmeal, quinoa, polenta, wheat bread, whether it's gluten or gluten-free. And I had to add that because a lot of them could have celiac, or they're avoiding gluten because it doesn't make them feel good. But again, carbohydrates are not bad. I think it's the type of carbohydrates that we need to focus on. So I always encourage to treat the grain as a side of the meal as well, so we allow more room for fruits and veggies and legumes. Our culture here, and it's very easy to eat a whole big plate of pasta and minimal vegetables. So how do we change that up where that pasta is more of the corner of the plate and there's more vegetables in that pasta? So that's how it's kind of looked at, but we have to gather baseline data from the patient to help make these changes. So I find I've been very, very successful with helping the patients build up the food groups one by one. So that way they practice. And then from there, as soon as they start giving me their own ideas, I know something has clicked in them. I find a lot of my patients have come my way that they're I can never have sweets again. I'm like, no, it's the how to aspect. So not eating sweets daily, treat them as bites and sprinkles, share them with others. So these are common options that I've given my patients. Pair them up with a food that we often recommend. And again, are you eating it 3-4 times a day? Are you eating a big plateful? Are you eating them as a side? So this has helped improve adherence to eating less sweets because they know they can. It's just that when you're told you can't have something, then what happens? You want it more and more. So we don't want our patients being in that cycle either. And then finally, engaging into physical activity. Further studies are needed to really what type and duration of physical activity that can help to reduce NAFLD. But again, where's that starting place? Can you do a 15-minute walk daily? Again, if that patient feels safe to do it, it's accessible, it's doable. What is a muscle strengthening activity? Even if it's lifting heavy cans around the house once a week. I'm beyond not a physical therapist or an exercise trainer, but this is definitely something that is a gap in our clinic care is, how do we do this? So walking can be the simplest form. And eventually the goal is to meet the physical activity guidelines or even more than that. And here's a list of apps that I've been successful with or patients have really enjoyed to apply resistant band type of exercises, or even the 7-minute workout. That's been pretty quick. I've tried it. But again, anything to get them moving, parking their car further away, walking around the airport, it's all going to help. And then finally, what I can end it with is that here are some practice recommendations that I can leave you with. For educational key points and, certainly discussing rationale and indications for a plant-based diet. Just know that everyone eats differently, everyone feels differently. So it's really important to engage the patient on what's going to work for you. Here are the guidelines we're presenting. How can we break this down? Where do you feel comfortable in starting and practicing? And definitely referral to a registered dietitian, I'm biased, it will help from that angle because we focus on implementation. This is what we do on a day-to-day basis. And when my goal is always to promote a sustainable way of eating. You should be able to do this a year from now or 5 years from now, not a quick fix. And then because our food choices are reflective of culture, access to foods, how much time we want to spend in the kitchen, our skills in the kitchen, our what we like, what we dislike, all going to come into play with this. So we need to be able to respect the variety that patients want to have for them to adhere to this. And with that, thank you for your time.
Thanks so much, Neha, especially those recommendations for the apps and your pinpoint recommendation in terms of the different food groups. And I think we just all appreciate just learning how you approach patients, and that way we can also model some of that when we see our own patients. There is, one of the fellows had asked a question about the intermittent fasting. I think that kind of leads up to another question too, where I know like definitely the recommendation and most popular diet that you mentioned is Mediterranean, but then intermittent fasting or like the Atkins or the low carbs, I guess like what are your thoughts on those and
yeah,
how
absolutely. I can go in order. So let's start with intermittent fasting because that's the focus of the question. So I do have a lot of patients on it. It is something that has helped promote weight loss. I would have to say in order for intermittent fasting to be quite successful, then it's really on the patient's shoulders to eat within a certain time and then kind of modify their day to help with that. And then that's where many of the patients have not been able to do that because each day we all know we do different things on different days, what we do on weekdays versus weekends. I come from a perspective, if they want to try it, usually you fast for 16 hours and you eat within an 8-hour time frame. I will encourage it, fine, but again, it doesn't mean that you not eat your fruits and not eat your vegetables, like how do we develop a sustainable way of eating within that intermittent fasting? And some of my patients really like it and they're doing it for most days of the week. And then some people are just like, I can't do this. Each day is too crazy. I need to be able to eat my meals when I can. I'm like, okay, well, so it's not a no for me. I will help my patients with that. It has been shown to reduce NAFLD and promote weight loss. But I think it goes back to the patient on how it always goes back to the patient of how they can implement this in their day-to-day life.
awesome.
Atkins, paleo, gosh, what other low carb diets out there? There's so many out there, Whole30. I would have to say that I've had patients on them, but it has not been sustainable. So those diets will achieve weight loss. It's known to do that. And then what happens is that it's not sustainable and then the weight gain comes back. And this creates a cycle of guilt and shame as well. A lot of my patients will say, I failed. I tried this diet. I lost the weight. I was doing so good. I was being good. And then now I'm being bad again. And that type of thinking can lead to disordered eating. And what I usually will tell my patients, yes, it has achieved what we wanted to achieve, but it's actually not meant for a sustainable weight loss. Unless you feel like you want to do this for the rest of your life, then we find a way to do that, But if your desire to, and two questions I will ask my patients, are we aiming to modify your life around a diet, or are we aiming to insert this diet in your way of life? You tell me, what are your goals here? It's always if they're trying to figure out ways to do their day-to-day thing and while following a certain way of eating to reduce NAFLD. So I think with the low carb diets, yes, it can be successful. From my experience with my patients, it has not been sustainable, and I have not encouraged it because of that reason.
Yeah, man, I love how you keep on using the word sustainable, because I think that's part of one of the most important part. Even that triangle graph that you showed at the pivotal study about weight loss. I mean, you look at that, it's like less than 7% achieved it, and then you look at a year later, and sustainability is like less than 5%.
Yeah.
And sticking with sustainability, I guess one quick question is, I feel like sometimes with these nutritional recommendations you kind of allude this at the last slide, it's dependent on social economic and as well as other factors. And For patients who may not be in the most financial stable, is there any resource that you may have on your website or some other website that can offer to some of our patients in terms of kind of what you suggested, like, try these food, but in a more affordable manner?
Yeah, I definitely. I think it really depends on their socioeconomic status. I do encourage frozen fruits and vegetables as an example, because they can last longer in the freezer. The generic store brands are going to be cheaper than a fancy another brand. I think again, it depends on their level of socioeconomic status. There's SNAP benefits, which would help. This is where a social worker, again, a multidisciplinary team could be of help. Learning a little bit more about food banks, and then what's going on in the home. If they're, it really requires an assessment of what's going on and working backwards. So making substitutions on what's their current way of grocery shopping, and then finding alternative brands, alternative ways to buy those same foods. Batch cooking is something I encourage. So if you're gonna make eggs, maybe get a 12-sheet muffin pan and make egg muffins, and it can last like between the whole family for a week. So batch cooking can also be a part of that. From that angle, looking for sales. There's always something on sale at the grocery store. And certainly where they're going grocery shopping. Some of these specialty grocery stores, wow, they're quite pricey from that angle. So yeah, it's all like, my responses here are very general, but I think that's just some things that I look into to help my patients. Yeah.
And one thing that was brought up is, I think, is a lot, some of the questions that our patients proposed to us, but artificial sweeteners, and use of those, as well as, say, like, Diet Coke or Pepsi Zero. I guess, is there in your experience any harmful benefits in recommending
I haven't
those?
discouraged it. If that's something they want to try to help make substitutions, stopping anything cold turkey, it can be tough. So switching from regular soda to diet soda, that can be a step in that right direction. But again, it's going to be a focus on additions. If I keep on focusing on don't drink this, don't drink this, don't drink that, and not talk about the substitution with sparkling water, unsweetened coconut water that can have some club soda in there, or some club soda with some diluted fruit juice, then how do we add other beverages in that mix? I think with artificial sweeteners, I don't want to get into the whole gut and liver aspect. It was beyond the scope of the talk today, but we all know there is some in the literature of disruptions in the gut and liver axis that can lead to NAFLD, and artificial sweeteners. There's some research there as well to disrupt our gut microbiome from that angle. So from my perspective, if we're going to focus on unprocessed foods, I'd rather have them have a little bit of that honey or a little bit of that agave nectar versus an artificial sweetener that's been synthesized in a lab from that angle. A lot of these artificial sweeteners are also made from sugar alcohol. So if they're telling me that they don't feel good after eating them, like gas, bloating, this is where the GI side comes out from me. Then maybe it might be better just to switch over to the real thing, but do smaller amounts. And some of them are very happy to hear that.
That's really helpful. I mean, practicality and realistic expectations
Of
are always
course.
important.
Yeah.
I definitely, we're kind of heading towards the end of the hour
Okay.
already. Any other fellows on the
Any
call
other
right
questions, or you can email me. It's fine. I can put my email address in the chat box. Or if you want to send patients over my way, this is why I have a private practice.
That'd be awesome.
I don't see them at UCSF, but I was specializing in liver at Stanford Healthcare, but there.
Awesome. Thanks so much, Neha. And yeah, if there's no other questions, then I just want to appreciate you taking your time on your busy day to come and teach us, and also for the fellows and faculty for joining.
All right. Well, thank you for having me.
Good night, everyone.
Okay. Bye.
Thanks, Neha.
Thank you. Goodbye.
Bye, Neil.